Hi guys, give me a thumbs up if I'm visible to all of you and my audio is clear. So today we're going to spend 1.5 hours roughly talking about 5 important questions from nephrology. In the medicine papers, mostly it is the cardiology, respiratory medicine, neurology, and to some extent the critical care medicine, which takes the upper hand. Usually, the representation of questions from nephro and gastro is relatively less. Nonetheless, we will be spending 90 minutes covering 5 major lengthy questions from nephrology. We'll start with the basic questions and then we will get into the questions from acute kidney injury and chronic kidney disease. Okay. So the first question that we are discussing is related to symptomatology. This is a question which we have seen across many university papers. The question goes like this: define proteinuria, describe types of proteinuria, and write a diagnostic approach to proteinuria. Well, how do I define proteinuria? Simple conceptual definition is excretion of abnormal amount of protein in urine. That means some normal amount of protein is excreted in urine, but when it is more than that, we will call it as proteinuria. So you can write it as excretion of abnormal amount of protein in urine. Abnormal amount of protein in urine. Now, normally what happens, the large molecular weight proteins are not filtered in the glomeruli and we do not excrete them. But some small molecular weight proteins do get filtered, like Tom House-Paul protein, and we do excrete them. But what is the normal daily excretion? The normal daily protein excretion is less than 150 milligrams per day or per 24 hours. Anything more than this can be considered as proteinuria, right? Simple as that. But now when I say normal daily protein excretion, it is largely comprising of non-albumin proteins, right? Small molecular weight proteins. But we do excrete a small amount of albumin. So how much is the normal daily albumin excretion? The normal daily albumin excretion in urine is less than 30 milligrams per day. So when your daily protein excretion is more than 150 milligrams per day or your daily albumin excretion is more than 30 milligrams per day, we can say patient has got proteinuria. And precisely if it is albumin which is more than 30 milligrams per day, we can also write it as albuminuria, right? So in the definition, we can certainly mention this, that urine albumin more than 30 milligrams per day, and urine protein which includes albumin more than 150 milligrams per day is abnormal and it is suggestive of proteinuria. This condition where albumin is more than 30 per day, 30 milligrams per day, we can specifically call it as albuminuria. Okay, so that completes our definition, and generally the definition is going to carry 1 mark. Mostly these questions are going to be 5 marks questions. So 1 mark we are giving for the definition. Then the types of proteinuria will carry 2 marks and another 2 marks for the diagnostic approach to a patient presenting with proteinuria, right? So let us now talk about the types of proteinuria. How many types of proteinurias are there? So there are again different ways of classifying proteinuria. Quantitatively, we can say that microalbuminuria, macroalbuminuria, nephrotic range proteinuria, that is just a quantification method. But based on the cause, we can also classify them as orthostatic proteinuria, glomerular proteinuria, tubular proteinuria, and overflow proteinuria. Okay, so what is this orthostatic proteinuria? It is due to prolonged standing. And this is self-limiting or benign. It is self-limiting or benign. So you don't need to treat these patients. Okay. Second is glomerular proteinuria. So basically there is injury to the glomerulus and you are losing glomerular proteins or large molecular weight proteins. So it is due to glomerular injury, and that can include albumin and non-albuminous proteins, because Albumin is not much filtered by glomerulus, but if I cause the injury, then albumin is being lost, right? Albuminous as well as non-albuminous proteinuria. Now, what can cause the glomerular injury? You can definitely mention the long list of glomerular disorders, right? Post-streptococcal glomerulonephritis, IgA nephropathy. You can go on listing few examples as the causes. Okay. Now, tubular proteinuria. Now, normally what happens is some small molecular weight proteins reach the tubules, reasonably they are reabsorbed, and then some are lost. So when there is tubular injury, we will also lose some amount of proteins. These are basically small molecular weight proteins. This is usually non-albuminous proteins, mainly comprising of Tom Horsfall protein and other small molecular weight proteins. So this tubular proteinuria is due to tubular injury, and it mainly contains non-albuminous proteins like Tom Horsfall protein. Tom Horsfall protein. Okay. Then we have overflow proteinuria, where there is excess protein in the body and we are unable to reabsorb a reasonable amount of it, and we end up losing them, right? Example, due to excess protein. Example is multiple myeloma. Multiple myeloma. This is a very simple classification of causes for proteinuria. If you want, you can also write one more classification for proteinuria, which is based on the quantity, right? If you want, I'll write it down. Quantification of a proteinuria. Primarily, we focus on albumin because the proteinuria is particularly having a diagnostic relevance when it comes to glomerular disorders. Knowing whether it is in the nephrotic range or non-nephrotic range helps us to differentiate different possible causes for the glomerular injury. So I'll write it down. So let us say when I got a patient with proteinuria, how will I approach? The initial investigation is usually the urine dipstick. What examiners expect here? The examiners expect here that you mention that there is a limitation to this dipstick. What is the limitation of the dipstick? The limitation is that the dipstick tests that we do for the urine protein, they do not detect non-albuminous protein. They can only detect the albumin. So if dipstick is positive, that means there is albuminuria, but dipstick negative does not rule out proteinuria, right? So that is why when we are suspecting, we have to do a quantitative test. What alternative I can do for the, let us say, for initial investigation? Another alternative I can do is urine spot protein creat ratio. That can also be done. Okay. Now quantitative test wise, what I can do? I can do 24-hour urine albumin estimation, or I can also do urine albumin creat ratio. This urine albumin creat ratio, we will abbreviate it as UACR. This will give us a quantified estimation of the protein. Okay. So let us say, how do we approach for the quantified classification of proteinuria? So if there is a patient with proteinuria, if the urine albumin, the 24-hour urine albumin is less than 30 milligrams per day, that is 24-hour urine albumin, of course this is normal. Okay, then if the 24-hour urine albumin is 30 to 300 milligrams per day or per 24 hours, in that case we will call it as microalbuminuria. And if it is more than 300 but less than 3500 milligrams, that is 3.5 grams, means 300 milligrams to 3.5 grams. 300 milligrams to 3.5 grams per day. 24-hour urine albumin. If it is in this range, we will call it as macroalbuminuria. Macroalbuminuria. And the last one, when it is more than 24-hour urine albumin is more than 3.5 grams per day or per 24 hours, we will call it as nephrotic range proteinuria. Nephrotic range proteinuria. So this is a quantification based classification of proteinuria. And here we can also apply the urine albumin create ratio. Now what is this urine albumin create ratio? We are measuring the amount of albumin in a single sample instead of taking 24 hours, right? For this, I need to collect 24-hour urine albumin. 24-hour urine is required. Instead, I can take one single sample of urine. I will estimate the albumin in urine and I will estimate the creatinine urine and I will express that ratio. The normal ratio, the normal urine albumin create ratio is less than 30 milligrams of albumin for every gram of creatine. So you can say it is less than 30. Same applies here. The urine albumin create ratio means for every 1 gram of creatine, how much albumin is excreted in urine? It is 30 to 300 for 1 gram of creatine. So the numbers are very easy to remember, right? Remember the same numbers that we are writing for 24-hour urine albumin. So USCR less than 30 is normal. USCR 30 to 300 is microalbuminuria. USCR urine albumin create ratio of 300 to 3.5, 300 milligrams to 3.5 gram of albumin for every 1 gram of creatine excreted in urine is macroalbuminuria, and USCR greater than 3.5 gram per gram of creatine is our nephrotic range proteinuria. So this is the classification of causes for proteinuria. After that, we will write an algorithm for the approach to proteinuria. And this is the most important part that examiners are particularly looking at. Like, okay, so now we know what is proteinuria, what are the common causes, and how do we differentiate between the different ranges of proteinurias, micro, macro, and nephrotic range. And then coming to how do you evaluate a patient presenting with the proteinuria, right? So proteinuria on urine dipstick, that is our initial investigation, right? Simple and quick investigation. Limitation, I have already told you. The limitation is that this cannot estimate non-albuminous proteinuria. So if you're suspecting that patient may be losing non-albuminous protein, then you have to do other investigations. Maybe urine protein create ratio or something like that, and not the dipstick. But for clinically, the dipstick is the most important investigation because majority of the causes where proteinuria is useful for the diagnosis of underlying causes, the glomerular disorder, where we will have albuminuria, right? Like for example, your diabetic nephropathy. So once there is proteinuria on the dipstick positive, if that is positive, we have to go ahead for the further evaluation. What is the further evaluation? We have to quantify. So we have to either do a 24-hour urine protein estimation or albumin estimation, or the morning spot sample albumin create ratio. This is what we call as urine albumin create ratio or USCR. If it is less than 30, of course that is normal, but if it is 30 to 300, we would call it as microalbuminuria, as I've told. And then what conditions we can think of for microalbuminuria? If someone presents with microalbuminuria, the most common cause is diabetic nephropathy. The most common cause for microalbuminuria is diabetic nephropathy. And the primary or essential hypertension is the second most common cause for microalbuminuria. So you can say that hypertensive nephropathy and diabetic nephropathy are the leading causes for microalbuminuria. So whenever someone comes to you with a urine report and it shows some dipstick 2 plus, 3 plus, 1 plus, that means there is proteinuria, right? Ask them to do a 24-hour urine albumin or urine albumin create ratio. And if the ratio falls in the micro range, first thing that should come to your mind is easy a diabetic and easy well controlled, easy a hypertensive, easy well controlled. Okay. Apart from that, early stages. So this is the first cause that you have to mention, the diabetes. Second is hypertension. Third is early stages of glomerulonephritis like PSGM and all. They can have microalbuminuria. But if it is in the macroalbuminuria range or the nephrotic range, this is unlikely to be early stages of diabetic nephropathy or the early stages of hypertensive nephropathy. This could be mostly because of glomerulonephritis. That is one possibility, right, where you can have even the nephrotic syndrome presenting in adults. So if I have macroalbuminuria or nephrotic range proteinuria, I have to go for urine analysis to get the further leads. So if on the urine analysis, I'll get what? RBCs, especially if the RBCs are dysmorphic, or if I get RBC cast. What does that suggest? So remember, presence of RBC cast or dysmorphic RBCs on urine analysis is suggestive of acute glomerulonephritis. It suggests of glomerular injury, right? So now I have to think of the glomerulonephritis causes, like PSGN is a possibility, right? Membranoproliferative glomerulonephritis is a possibility. Lupus nephritis is a possibility. Other post-infectious glomerulonephritis is a possibility. Right? Goodpasture syndrome is a possibility. All these glomerulonephritis is what I should be thinking of if RBC cast are present, or RBCs, especially the dysmorphic RBCs are present, RBCs which are disfigured. Dysmorphic RBCs are present, then it is suggestive of glomerulonephritis or glomerular injury. Glomerulonephritis or glomerular injury. So now for establishing the underlying cause, I will go for further evaluation. Right? I will do blood cultures, anti-glomerular basement antibody, right, ANCA, complement levels, cryoglobulins, hepatitis B, C serologies, VDRL, HIV test, and even anti-streptolysin O antibody titers. You can mention 3-4 investigations, it's more than it. Just to tell that you know that this patient is having glomerulonephritis and you know that you need to investigate further. Okay. And if you have got the nephrotic range proteinuria, but there are no RBC casts or the dysmorphic RBCs, then we would think of nephrotic syndrome, right? Now, in a pediatric age group, nephrotic syndrome is almost always because of the minimal changes. For adults, it's not the case, right? So there are various other causes for nephrotic syndrome in adults. So you should mention the causes: diabetic nephropathy, amyloidosis, and FSGS. These are the three important conditions you should mention in the nephrotic syndrome when it comes to adult question. In pediatrics, you can and you should mention minimal change disease. If you skip minimal change disease, writing it in adults question, it's fine because it is relatively less common. But FSGS, amyloidosis, and diabetes, I want you to mention without fail. Diabetes, amyloidosis, and FSGS, and also membranous glomerulopathy. Okay, IgA nephropathy, if you skip it's fine because most cases of IgA nephropathy present with painless hematuria and unlikely that they will land up with nephrotic syndrome. Okay, so this is the approach that you need to write. And for further diagnosis in these conditions, you can write one statement saying that when the diagnosis is not evident at this level, renal biopsy is indicated. That is the gold standard whenever you are suspecting a renal pathology, right? So that completes our 5-mark question on the proteinuria. Similarly, they can also ask you about the hematuria. And in hematuria, there are a few terms that they ask you to define. What is hematuria? What is significant hematuria? What is persistent hematuria? How to differentiate between glomerular and non-glomerular hematuria, just like how to differentiate between tubular and glomerular proteinuria, how to differentiate between glomerular and non-glomerular hematuria, and they will also ask you to write approach to hematuria. So this can be a 5 or a 10-mark question. So let us see how do we write it for 10 marks. So if it is a 10-mark question, the definition of hematuria will carry 1 mark, right? Then the definition of significant or persistent hematuria will carry 2 marks. The differentiation between the glomerular and non-glomerular hematuria will carry 2 marks, and they will give 5 marks for the short note on approach to hematuria. So we'll begin with the definition. What is hematuria? In simple words, presence of RBCs in urine can be called as hematuria, but it has to be more objective. So what is the objective definition? Because randomly you check somebody's urine sample, sometimes they will mention 1 RBC seen per high power field. So is that hematuria? No. Hematuria is defined as presence of more than or equal to 3 RBCs per high power field in urine. So when you do urine microscopy, in every high power field, on an average, 3 or more than 3 RBCs are seen, then we will call it as hematuria. Okay. Now, hematuria can also be transient. Many times after vigorous exercise and all, people may have hematuria. Even after the intercourse, people may have some degree of hematuria. That did not mean that they have a major problem. So then comes another important definition here. Significant or persistent hematuria. What does that mean? See, mere hematuria is not very important. It is the significant hematuria or persistent hematuria which is important. So what is significant hematuria? When you have more than or equal to 3 RBCs per high power field on more than or equal to 3 samples or 3 occasions. 3 times I have taken urine samples, and in 3 or more than 3 of those urine samples, I can see that there are 3 or more than 3 RBCs per high power field. So it's easy to remember 3, 3. Second is more than or equal to 100 RBCs per high power field on single sample. So if I get one sample where the RBCs are more than 100 per high power field, then it is significant hematuria. I don't have to look for second sample, third sample. But if it is less than 100, then only when 3 samples show that there are more than or equal to 3 RBCs per high power field, only then I can call it as significant or persistent hematuria. The meaning of both is same here. And then third, gross hematuria, where from the naked eye only you know that patient has blood in urine. Gross hematuria will also be considered as persistent or significant hematuria. Now, why this is important? Presence of significant or persistent hematuria indicates a renovascular pathology. Means just having hematuria need not always be indicating a renal pathology. Just I have told you that after exercise or intercourse, people can have hematuria. So a single hematuria is not always pointing towards a pathology. But if you have persistent hematuria as defined by these criteria, you must be having a renal or renovascular pathology, kidney or blood vessel pathology. That is why it is the significant or persistent hematuria cases that call for the investigation. Okay. Now the question is, how do we differentiate between, once I know that there is hematuria, I know that there is some significant renal pathology, and for me to take it forward, I need to know from where this blood is coming from, or from where these RBCs are coming from. Are they coming from glomeruli? Are they coming from the renal tubules or rest of the kidney? Or are they coming from even the ureter, urethra or bladder, right? At least we can do this. Whether it is coming from the glomeruli or rest of the kidney and the urinary system. This can be differentiated, right? So we can differentiate whether these RBCs are coming from glomeruli or from the non-glomerular sources. How do we differentiate? Okay, so non-glomerular hematuria generally contain normal appearing RBCs. On the other hand, the glomerular hematuria will have RBCs which are dysmorphic. Why? Because the RBCs are passing through those injured glomeruli, and when they pass through, they get damaged. So we'll have dysmorphic RBCs in glomerular hematuria. On the other hand, non-glomerular hematuria, we will have normal RBC morphology, or you can say no dysmorphic RBCs or normal RBC morphology. Okay. And then if there is glomerular injury, they may be associated with RBC casts. They may be associated with RBC cast. If it is non-glomerular hematuria, there will be no RBC cast. So what are these RBC casts? Basically what happens is, in your collecting duct and collecting tubules, as the urine flows through them, the Tom Horsfall protein, the small molecular weight proteins which are filtered from the glomeruli, are passing through this. They settle here and form a cast, and they take the shape of the tubule. This cast is called as hyaline cast. So hyaline cast is normal. But if RBCs are coming from the glomeruli, those RBCs will get come here and get impregnated on these hyaline cast, and this cast now becomes RBC cast. The presence of RBC cast is suggestive of glomerular hematuria, and this is an important MCQ point. Even a single RBC cast, if you see on urine microscope, it is always suggestive of glomerular hematuria. One or two dysmorphic RBCs may not be strictly suggestive of glomerular hematuria, but a single RBC cast also is seen on microscopy, then patient has got glomerular injury. Okay, so that is the second thing. Then third thing, the non-glomerular often may have frank blood, or there may be blood with clots. Blood with clots, especially when it is the bleeding is happening in the bladder, you will have blood with clots. On the other hand, the appearance of glomerular hematuria is more because the RBCs are damaged, they get lysed, and the glomerular hematuria ends up looking, if it is grossly visible, it ends up looking like cola colored, right? So you may have cola colored, or the hematuria may be microscopic, or you may have cola colored urine. So these points you should write so that examiner knows you know how to differentiate between glomerular and non-glomerular hematuria. Okay. So now, how will I approach a patient presenting with hematuria? Again, it is very simple. The step number one is to differentiate whether it is glomerular or non-glomerular. So that is why the Harrison's algorithm starts with whether there are dysmorphic RBCs or RBC cast present. If dysmorphic RBCs or RBC cast are present, what is it suggestive of? It is suggestive of glomerular hematuria. There is injury to the glomeruli, and that's why patient is having hematuria. We need to now investigate the causes for the glomerulonephritis, right? So the same table we have put here also in the approach to proteinuria, right? Exact same thing you can copy here, because now we are thinking of glomerular disorders. Whatever tests we need to do for diagnosing the glomerular disorders, we will go ahead and do. Okay. If these are negative, means there are no dysmorphic RBCs or RBC, that kind of rules out the glomerular pathology, and I should start thinking of non-glomerular source for the RBCs. So it could be pyelonephritis, interstitial nephritis, right? So that's why we are looking at some other parameters. Okay. So what we will be further looking at the urine routine, I will look at whether there is pyuria or WBC cast. What WBC cast and pus in urine is suggestive of? These are suggestive of pyelonephritis, right? Infection of the kidneys, pyelonephritis. They are suggestive of pyelonephritis. If they are present, then I will go ahead with urine culture and urine for eosinophils. And that takes me to the diagnosis. Further investigation is based on imaging. I will do an ultrasound or a CT scan to identify that there is perinephric fat stranding and collection of pus in the kidney, hydroureter or nephrosis. But if these are also negative, glomerular is ruled out when there is no dysmorphic RBCs or RBC cast. Then there are no WBC cast or pyuria, so pyelonephritis is also ruled out. Now I have to think of other causes for hematuria. So I can do hemoglobin electrophoresis, mainly suspecting sickle cell disease, like urine cytology, right? Then 24-hour urine calcium, uric acid, to think of renal stones as a possible cause. And if nothing is found here, then I have to go for imaging, right? Imaging, intravenous pyelogram with or without renal ultrasound. In practice, we begin with ultrasound instead of jumping to pyelogram. Harrison's algorithm says pyelogram with or without renal ultrasound. Based on what findings we get on this, we will do further evaluation, right? And always remember, any case when you're writing about nephrology, you don't find an answer. End approach is always doing the renal biopsy. So always mention that if cause is not identified on approach that we have discussed, renal biopsy should be considered. Okay. Now in the algorithm, I will also find that cystoscopy is recommended. What is cystoscopy? If ultrasound is not able to find anything, intravenous pyelogram is not able to find anything, cystoscopy is recommended. What is cystoscopy? Visualizing the bladder. We put a catheter with a camera into the bladder and visualize the bladder. So if there are any urogenital abnormalities visualized, we can do the biopsy and evaluate and treat accordingly. If that is also not helpful, then we go for the renal CT scan. And if you see something on the CT scan, you can take the biopsy of that lesion. Many a times what happens is we don't find a cause for hematuria. Patient will have persistent hematuria. In such cases, a close periodic follow-up is recommended. In the future, some sign will emerge and that will take us to the diagnosis. So what I want you to write in the approach, main thing that as an examiner I will be looking for is whether you can differentiate two pathways for glomerular hematuria and non-glomerular hematuria. That's the most important thing when it comes to writing an approach to hematuria. So that completes our answer on hematuria. There are two algorithms or flowcharts that we have discussed today. Try to memorize and recreate them in the exams to get the maximum out of those questions. Okay. Now we will go to our next question, which is on acute kidney injury. Here, a lot of memorization is required, and I would recommend that at least 1 hour you spend today after the class and try to memorize some key points. Okay, we'll start with AKI. What is the question? Define acute kidney injury. Usually, this is going to be a 10-mark question, and the definition itself will carry 2 marks because there are a lot of numbers here. And then they will ask you to classify the acute kidney injury, which will carry 3 marks because it is not just the classification but also mentioning the causes under individual classes: pre-renal, renal, and post-renal. Then the staging of acute kidney injury, that will carry 2 marks. There are 2 staging systems here. One is the KDIGO staging and the referral criteria. And then a short note on its management, that will carry another 3 marks. So in the management, you have to write about evaluation, complications, and management, right? So we'll begin with the definition. What is acute kidney injury? Definition can be conceptual, or you can directly write the objective criteria. What is the concept? Kidney injury or renal failure simply means that your kidneys are not able to do their task. They have plenty of tasks: urine excretion, potassium regulation, sodium regulation, water regulation, right? Acid-base balance, erythropoietin production, blood pressure regulation. They're not able to do their job. When that happens abruptly, it is acute kidney injury. When it happens over a period of time, usually more than 3 months, then it is chronic kidney disease or CKD, right? So we will define it as acute or abrupt cessation. Abrupt cessation of renal functions. When they're not able to function, what happens? There will be accumulation of fluid, which is supposed to be eliminated by kidney, and the nitrogenous wastes like urea and other nitrogenous waste that kidney is supposed to eliminate, they are not able to eliminate and it accumulates. This is a simple conceptual definition. But what examiner is looking for is this, the criteria. Even if you don't write it, it's fine, but the criteria should be mentioned. When do I know that it is acute? Right. The tests that we do for assessing the kidney functions are the creatinine and blood urea nitrogen or blood urea. So if they rise, that means there is renal dysfunction. But when do I consider it as AKI and when do I consider it as CKD? Right. So time becomes important parameter here. So when your serum creatinine rises by more than or equal to 0.3 milligrams per deciliter within 48 hours, you can say it is acute kidney injury. Just to give you an example, let us say there was a person whose creatinine was 1.4. Okay, this is his baseline creatinine. Now, in a time span of less than 48 hours, right? Like let us say I have checked it after 36 hours. Okay, and it has become now 1.8. So it has increased by 1.8 minus 1.4 is 0.4. So it is definitely increased by more than 0.3 milligrams per deciliter within 48 hours because the time gap between the two tests is just 36 hours, as I told. So then this patient has got acute kidney injury. Okay. The second criteria is increase in serum creatinine 1.5 times the baseline. 1.5 times baseline within 7 days or 1 week. Then also it is acute kidney injury, right? Like let us say this patient's creatinine, I checked after 48 hours and it has become 1.6. At this point of time, I can't call it as acute kidney injury, right? But I check again after another 48 hours and now it has become 2.4. 2.4. So overall, from baseline 1.4, it has become 2.4 and it is taken 48 plus 48. So it is taken 96 hours or 4 days, right? It is taken 4 days. Can I now call it as acute kidney injury? Of course, yes, because it satisfies this criteria. Baseline was 1.4, right? 1.5 times of 1.4 is 1.4 plus 0.7. That will become 2.1. So if the creatinine jumps to 2.1 or more within 7 days from this point to 2.1 within 7 days, we can call it as acute kidney injury. In this scenario, yes. If I take this as the baseline also, then it is satisfying the first criteria. If I take the whole story, then it is satisfying the second criteria, right? These are two number-based criteria. There is also a urine output-based criteria for defining the acute kidney injury. What is that? Urine output less than 0.5 milligrams per kg body weight. Sorry, 0.5 ml per kg body weight per hour for more than or equal to 6 hours. Means for at least 6 hours, the patient's urine output had been less than half an ml per kg per hour. Like, let us say first hour, let us say we are talking about a 50 kg patient. Okay. We have checked his protein urine output in first hour, second, third, fourth, fifth, sixth hour. Let us say in the first hour, the urine output was 10 ml. That means how much ml per kg? If it is 0.5 ml per kg per hour, then it should be 25 ml, right? Half of it. So it is less than that, less than 25 ml, right? In the second hour, it was 20 ml. In the third hour, it was 5 ml. In the fourth hour, it was 20 ml. In the fifth hour, it was again 15 ml. In the sixth hour, let us say it was 12 ml. Consistently for 6 hours, the urine output is less than 25 ml. That is less than 0.5 ml per kg per hour for this 50 kg individual. Then we will call it as acute kidney injury, right? So this is the objective definition. This is the conceptual definition. When both are mentioned, that completes the definition. I have completed already the proteinuria and hematuria. Okay. So now coming to the classification of causes. Now we know what is acute kidney injury. Now we will look at the classification of causes for acute kidney injury. Right. The causes will be divided into pre-renal, renal, and post-renal. You can either put a flow chart and write it down, or you can also put a simple diagram. Right. Like let us say this is aorta, and from aorta I am getting a renal artery. Okay. Then I have the kidney, and then from the kidney I am getting the ureter, and the ureter is going to the bladder, and then I have the bladder outlet. Okay, so the diseases that are going to affect the blood flow to the kidney, we will call them as pre-renal, right? Diseases that are going to affect the kidneys directly will be renal, and the diseases that are going to affect the ureter, bladder, or the urethra or the outflow tract will be called as post-renal. So you can say pre-renal and then mention causes under it. Then you can write renal here and mention the causes under it. And then here you can label it as post-renal and you can mention the causes under it. Right? Or you can put simple flowchart like this: pre-renal, renal, post-renal, and you can mention the causes. Okay, so what is pre-renal? Pre-renal is due to decreased renal perfusion, or you can write it as decreased renal blood flow. Okay. Now, what are the common causes? Why the blood flow to kidney gets compromised? What are the common causes for pre-renal AKI? One, hypovolemia, because of whatever reason. Hypovolemia, because of dehydration, because of acute gastroenteritis, right? Because of blood loss. You can mention if you want. Then second, sepsis. Sepsis. Why sepsis causes pre-renal AKI? Sepsis causes peripheral vasodilatation. So peripheral blood vessels in your hands, feet, everywhere in the skin, they get dilated. More blood goes to those dilated blood vessels. Less blood is going to major vital organs. So the blood flow to heart, brain, kidney gets reduced. That can cause pre-renal AKI, right? Then, what other conditions you can mention as cause for pre-renal AKI? How NSAIDs cause acute kidney injury? See, when blood flow to kidney comes down, right? Kidney, don't you think it tries to regulate the blood flow? Let us say this is one glomerulus that we are looking at. Okay. And this glomerulus is getting the blood from an afferent arteriole, and the blood goes out from this after the filtration through an efferent arteriole. Right? Blood comes in, and then some amount of get filtered, unfiltered goes out through efferent arteriole. Now, what I can do, if the blood flow to the kidney comes down, right, then the filtration will come down. So now to maintain the filtration, I need to increase the blood flow to kidney. And I can try to do that by two alterations. One, I can dilate the afferent arteriole, or I can constrict the efferent arteriole. So how can I dilate the afferent arterioles and how can I constrict the efferent arterioles? So efferent arteriole constriction, afferent arteriole dilation can help me to re-establish good blood flow to the kidney even when the amount of blood coming to kidney is reduced. So this dilation can be achieved by prostaglandins, and constriction can be achieved by angiotensin 2. Angiotensin 2. Now, if I give NSAIDs, what happens to prostaglandins? They are blocked. So when the blood flow to kidney comes down, if you are on NSAID, you may not be able to dilate the afferent arteriole. So you may not be able to improve the blood flow to kidney, and you may not be able to improve the renal function. So NSAIDs can also cause pre-renal acute kidney injury by inhibiting the prostaglandin production. So NSAIDs can cause pre-renal acute kidney injury. Okay. AC inhibitors can also cause pre-renal acute kidney injury because AC inhibitors dilate the efferent arteriole by reducing the angiotensin 2 production. So AC inhibitors and ARBs are also known to cause. ARBs are also known to cause. Right? So these are the common causes for pre-renal acute kidney injury. Okay. Then we have the renal. Pre-renal is simple. Anything that reduces the blood flow to kidney, right? Hypertension, hypovolemia, sepsis, drugs, they can cause. Renal, multiple structures in the nephron can be injured to cause renal type of acute kidney injury, right? Because in the kidney we have a nephron, right? And nephron has parts, right? What are the simple parts? Nephron has a glomerulus, then nephron has tubules, right? And surrounding these tubules we have the connective tissue, right, which we will call as interstitium. So now the damage to glomeruli can cause renal dysfunction, damage to tubules can cause renal dysfunction, and damage to the interstitium can also cause the renal dysfunction. So the renal type or renal causes for acute kidney injury, we will classify them into glomerular disorders, tubular disorders, and interstitial disorders, right? Three categories for the renal. So the first thing is our glomerular, which is the most common cause for renal dysfunction. Glomerular. Second, tubular. And the third one is interstitial. Interstitial causes, right? Glomerular causes. What are the conditions which can present as acute glomerular pathology? Post-streptococcal glomerulonephritis, IgA nephropathy, then membranoproliferative glomerulonephritis. Just few examples. These are all glomerular disorders which are going to present with acute kidney injury, right? And we also have tubular pathologies. What tubular pathologies? The renal tubules, the proximal convoluted tubules, the distal convoluted tubules, the loop of Henle, they can also get affected. What are the common causes for their involvement? One of the common causes that we encounter is drugs. Can you name some drugs which are known to cause tubular injury? For pre-renal AKI, we gave the examples, NSAIDs, AC inhibitors. Which drugs can cause tubular injury? The first drug that you should mention is amphotericin B. Amphotericin B, right? Second is aminoglycosides. Third, acyclovir. So these are few examples which will cause the tubular injury. Drugs. Okay. Then second, we have acute tubular necrosis due to pre-renal AKI. If the kidneys are not getting sufficient blood supply, they are also susceptible for ischemia. So eventually ischemia of the tubules will cause the tubular death. And one point I want you to remember here is this is the most common cause for acute tubular necrosis or ATN. So the tubular pathologies, we can call it as acute tubular necrosis. Okay. And what else can cause the tubular pathology acutely? Precipitation of large molecular weight substances in the tubules. For example, multiple myeloma. Right, all those proteins can cause renal dysfunction. Okay. Now, can you give some conditions where the interstitium of the kidney gets affected? Interstitial nephritis. We will call it as interstitial nephritis. So this we can call as glomerulonephritis. This acute tubular necrosis, and this we will call as interstitial nephritis. So interstitial nephritis is most commonly caused by drugs. It is basically a response to allergy. Means you expose the interstitium to something which we are allergic to, then body will mount an allergic response. So the most common cause for interstitial nephritis acutely is allergies, and allergies to drugs. And what is the most common cause of drugs, class of drugs? It is the beta-lactam antibiotics. Beta-lactam antibiotics. Your penicillin, cephalosporins. After that, patient starts having some renal dysfunction. And the best way to identify them is they will also often have drug rash, and they may have eosinophils in the urine. You know that allergy means eosinophils. So they will have eosinophils in the urine. Okay, so these are the causes for the acute kidney injury. Acute kidney injury. Okay, so the term azotemia and uremia are used interchangeably. So azotemia primarily refers to elevated nitrogenous waste, out of which urea is the most common or the largest, most abundant nitrogenous waste. So you can use azotemia or uremia interchangeably. Okay. So this is about the causes for the acute kidney injury, classified as pre-renal, renal. Then we have not mentioned about post-renal causes. Post-renal means obstruction. Simple thing is obstruction to urine outflow. Post-renal means there is obstruction to urine outflow. So what can be the cause? It can be caused by renal calculi, right? The stones or calculi. Then ureteric injury, right? Bladder cancer. In males, the benign prostatic hyperplasia. These are all common conditions, right? Yeah, the stones. See, the stones are usually located in the renal pelvis or the urethra or the bladder. So they will count as post-renal. Okay, so this is about our classification to causes for the acute kidney injury. Now the next important aspect of the question is where the examiner is objectively looking for is the staging of acute kidney injury. And there will be two stages, two staging systems. The first one is called as KDIGO staging. KDIGO staging. In this, the acute kidney injury is staged into 3 stages. 1, 2, 3. Okay, it's pretty easy to remember. For the diagnosis of acute kidney injury, we had 2 criteria, right? Creatinine based and urine output based. Creatinine based, what did we follow? Creatinine increases by 0.3 milligrams per deciliter or more within 48 hours, or it becomes 1.5 times the baseline within 7 days. And for urine output, what did we define? Less than half an ml of urine per kg per hour sustained for 6 hours or more, right? We will build the staging from this itself. So there will be 3 stages of acute kidney injury. First, let us look at the creatinine. What we are looking at, creatinine rising from, remember, the creatinine criteria had 1.5 times the baseline or more, right? So if it is 1.5 times to 2 times from the baseline, that will be called as stage 1. 2 to 3 times the baseline, it will be called as stage 2. And if it is more than 3 times the baseline, it will be called as stage 3. Easy to remember, right? 1.5 is the criteria for entry into AKI. From 1.5 to 2, we are going to call it as stage 1, 2 to 3, stage 2, 3 to higher, it will be stage 3, right? And also remember, any patient started on dialysis regardless of his creatinine, if I have to start him on dialysis, is always considered as stage 3, even if his creatinine was 2 times the baseline, but I had to start him on dialysis for some reason, I will always call it as stage 2. See, uremia is elevated blood urea, but urea is not the only nitrogenous waste in the body. So that is why collectively, when we say nitrogenous waste, we use the term azotemia, but it can be comfortably used interchangeably. Okay. So now we have this another staging criteria, which is called as Riffle criteria. Riffle criteria. So you should be writing both the KDIGO staging and the Riffle staging or Riffle criteria. Here, Riffle itself is a mnemonic which stands for risk, injury, failure, loss, and end-stage kidney disease or end-stage renal disease. Risk, injury, failure, loss means renal loss, and end-stage kidney disease or ESRD. Okay. So here, the parameters we are looking at is not just the creatinine or urine output, but also the GFR. Okay. Again, easy to remember. As long as you remember the stage 1, 2, 3 with creatinine, you also remember the risk, injury, failure. So stage 1 is nothing but our risk. Stage 2 is injury stage, and stage 3 is our failure stage. Means when the creatinine is more than 1.5 times the baseline, it is a risk. When it is more than 2 times the baseline, it is injury. And when it is more than 3 times the baseline, it is failure. Only thing that we are added here is the GFR. GFR decreases by more than 25%, more than 50%, or more than 75% is our risk, injury, failure. Okay. Then here we have 2 more things added. One is loss and end stage kidney disease. So what is the renal loss or acute renal failure? Means it refers to complete loss of renal function for more than 4 weeks. Means these parameters persisting for more than 4 weeks. And if the parameters persist for more than 3 months, then we will call it as end stage kidney disease, which is nothing but equal to CKD. So let me summarize again. If creatinine becomes 1.5 times the baseline, it is risk stage. If it becomes more than 2 times the baseline, it is injury. If it becomes more than 3 times the baseline, it is failure. That is our stage 1, stage 2, stage 3 according to the KDIGO staging, right? Now these abnormal parameters, maybe 2 times the baseline, 3 times the baseline, 1.5 times the baseline, anything that can be counted as acute kidney injury. If the parameters persist for 4 weeks or more, then I will call it as loss, renal loss. And if this abnormal test persists for more than 3 months, then I will call it as end stage kidney disease. Okay, I hope you are able to remember this. Now, we also have a urine output criteria that we need to remember. The urine output criteria. See here, the GFR is the estimated GFR, eGFR, not the actually measured GFR. It is the estimated GFR using the Cockcroft-Gault formula or the other formulas that exist today. Okay. So then we have the urine output criteria also that we need to remember. So how did we define AKI? Urine output less than half an ml per kg per hour for 6 hours or more, right? So if it is for 6 hours, then it will be called as stage 1. If it is for more than 12 hours, it will be called as stage 2. And slight change here, less than 0.3 ml for more than 24 hours, we will call it as stage 3. Same thing we will extrapolate to the Riffle criteria. Urine output less than 0.5 ml per hour for 6 hours is risk. For 12 hours is injury. And less than 0.3 ml for 24 hours is failure. Added thing here is no urine output or less than 100 ml per day is anuria. Anuria for 12 hours is also considered as failure. Okay. So this is our staging of the acute kidney injury, KDIGO and Riffle. So spend some time trying to remember these numbers because examiners are objectively looking for these numbers. Merely mentioning risk, injury, failure and end stage kidney disease, examiners won't give you any marks. They are looking for the numbers. Okay. So after the staging, let us talk about clinical features and management of acute kidney injury. Right? Management of course depends on the cause, whether it is pre-renal, renal and post-renal. But clinical features, common things we can write. So what is the function of kidney? Elimination of urine, but that is water regulation, sodium regulation, potassium regulation, right? And then acid-base balance. All of these are major functions and they get altered when the kidneys are going into dysfunction. So because of that, what symptoms we can expect? First, there can be decreased urine output. Right here, you should mention when do you call it as oliguria and when do you call it as anuria. So there may be oliguria when the urine output is less than 400 ml per day, and we will call it as anuria when the urine output is less than 100 ml per day. Okay. Second thing, patients can have increased blood urea and other nitrogenous waste, and they will lead to certain symptoms, right? What symptoms we are expecting when the blood urea level increases? What symptoms this can lead to? Urea is an osmotically active substance. So if anyone remembers the formula for serum osmolality, it includes three important components. What are the components of serum osmolality formula? Sodium, right? Blood urea, nitrogen, and glucose. These are the three abundant osmotically active substances in our blood. So if any of them increases, the serum osmolality increases, right? So because of that, one of the common problem it can lead to is it can lead to cerebral edema. It can lead to cerebral edema, and in that case we will call it as uremic encephalopathy. Uremic encephalopathy, because now the brain, which is edematous, cannot function properly. Second, high urea levels can also lead to pericarditis. We will call it as uremic pericarditis. Pericarditis. Being osmotically active, it can also cause hemolysis. High urea levels can cause hemolysis. High urea levels interfere with the coagulation cascade, and they can also cause bleeding diathesis, or tendency to bleed. And high urea levels in the blood are strong stimulant for the vomiting center in the brain, so they can be highly hematogenic. So when the urea level starts going high, patients will not tolerate food properly. They start puking out regularly, right? So it can also lead to severe nausea and vomiting. So these are some of the symptoms that high blood urea levels can lead to. Okay. Then what will happen to the because of the decreased urine output, what symptoms we are expecting? It can lead to edema. Okay. Then we are supposed to excrete the potassium. The job is done by kidneys, right? But there can be decreased potassium excretion. And what this can lead to? Decreased potassium excretion can lead to what we call as hyperkalemia, and hyperkalemia can lead to certain symptoms, right? What are the symptoms that we can expect? Hyperkalemia puts the person at increased risk of ventricular arrhythmias and sudden cardiac arrest. You are familiar with the ECG changes that we get, and cardiac arrest. The tall T waves, eventually sine wave, and eventually cardiac arrest. Okay. What else the kidneys are supposed to do? The regulation of hemoglobin is not usually altered in the acute kidney injury because the RBC lifespan is 120 days. So even if I momentarily stop producing erythropoietin, my hemoglobin is not going to drop within next few days or 1 or 2 weeks. But when I have chronic kidney disease, yes, that can get altered. So these are the important symptoms that we can mention when we are talking about acute kidney injury. Apart from that, based on the cause, patient may have hematuria or proteinuria if glomerulonephritis is present. Glomerulonephritis is present. Okay, so this is about the clinical features. Now, how do I evaluate a case of AKI? Evaluation of a case of acute kidney injury. So if I have a patient with AKI, which is defined by the creatinine or the urine output criteria, what is the single most important investigation that can help me to rule out the post-renal acute kidney injury? post-renal acute kidney injury. It is the ultrasound or the CT scan of the kidney. If it is suggestive of post-renal, like the calculi, benign prostatic hyperplasia or bladder cancer or something, the obstruction is visible, then we will treat accordingly. Anatomy hub, yes, yes. Okay, now if no post renal obstruction, there is nothing suggestive of post renal obstruction, what should I do next? Now that means I'm dealing with either pre-renal or renal because there is no post renal obstruction. So then it is suggestive of pre-renal or renal. Now the question is, how do I differentiate between post-renal and renal acute kidney injury? Okay, so we can write a short note on differentiating between post-renal and renal. Okay, let us put it as a flowchart itself. Can anybody tell me how do you differentiate between pre-renal and the renal acute kidney injury? Okay, so now I have to see is the urine microscopy. So if on the urine microscopy I see hematuria, right, or dysmorphic RBCs, or if I see RBC CAS, what is it suggestive of? It is suggestive of glomerulonephritis. Glomerulonephritis. Okay. If I see on the urine microscopy that there are no dysmorphic RBCs or RBC CAS, but instead I see something called as renal tubular epithelial CAS or muddy brown CAS. What is it suggestive of? And if I see only hyaline CAS or no abnormal CAS, what is it suggestive of? So if I see renal tubular epithelial CAS or muddy brown CAS, it is suggestive of acute tubular necrosis or tubule as a site of injury. And if only hyaline CAS or no abnormal CAS, it is suggestive of pre-renal AKI. Pre-renal AKI. But in many cases, the confusion will still prevail between pre-renal and ATM because this is pretty clear. If I see hematuria, dysmorphic RBCs, RBC CAS, it has to be a case of glomerular injury. I have already told you, even a single RBC CAS visible on the microscopy is always a glomerular pathology. But this differentiation requires further evaluation because it may not be very clear, or the RT CAS or muddy brown CAS need not always be clearly evidenced. So that's why in many universities, there is a 3-mark question as part of the 10-mark question asking you to write a short note on differentiation between the pre-renal AKI and ATM. So we'll put a small table, pre-renal AKI and acute tubular necrosis. Okay, so few parameters that we will discuss here. First one is the urine microscopy, which we have already discussed. Urine microscopy. So in the pre-renal AKI, it will show only hyaline CAS. Hyaline CAS. In acute tubular necrosis, we get 2 types of CAS: renal tubular epithelial CAS and muddy brown CAS. I will explain what these are. Muddy brown CAS. So basically, CAS is nothing but Tom Horsfall protein getting precipitated in the distal convoluted tubule and collecting ducts and taking its shape. That is a cast. A simple Tom Horsfall protein cast is called as hyaline cast, right? So Tom Horsfall protein cast is called as hyaline cast, which is seen in normal individuals, and pre-renal AKI is nothing but decreased blood flow, otherwise kidneys are fine. We'll see hyaline cast there for sure. Now on top of it, if I add RBCs, it becomes RBC cast. If I add WBCs, it becomes WBC cast. What is this RTE cast? RTE cast refers to renal tubular epithelial cell cast. So if the, let us say, proximal convoluted tubule here and loop of Henle, they are damaged, their epithelial cells will be shed into the lumen, and these cells will travel and then get impregnated on the hyaline casts that are getting formed in the collecting ducts. So now this cast has a sheet of Tom Oswald protein, and on top of that there is impregnation of these so-called tubular epithelial cells which have come from the damaged tubules. So if I see that the cells are impregnated, the tubular epithelial cells are impregnated on the Tom Oswald protein sheet, that means there is injury to tubules. Otherwise, from where these epithelial cells came, right? Now the same cast, if you allow it for some time, the cells will start getting degenerated. They will liberate a pigment called as lipofuscin that makes this cast now appear muddy brown cast. So basically muddy brown casts are aged renal tubular epithelial cast where the cells have started degenerating. Okay, that is one. Okay, second, if I check urine osmolality, what will happen to urine osmolality in pre-renal AKI and acute tubular necrosis? Where it will be increased, where it will be decreased, where you will have concentrated urine and where you will have dilute urine. Just think logically, right? In pre-renal AKI, what is happening to the blood flow to the kidney? Decrease, right? Because probably you have hypotension or hypovolemia. In this circumstance, you want the kidney to reabsorb more of the water or excrete more. Like normally we know, right? We bring the blood to the glomeruli, it filtrates, creates the glomerular filtrate, and then we excrete some amount of it as urine, but we reabsorb almost 90 to 95% of water, right? Now, in the circumstance where the blood volume is low, you want to reabsorb more or you want to lose more? Of course, we want to reabsorb more water, right? How do we reabsorb more water? We have a hormone called as antidiuretic hormone. See, remember, 90% of the filtered water is reabsorbed in the proximal convoluted tubule and 10% in the distal convoluted tubule and collecting ducts. This 90% is totally independent of your hydration status, right? Whether you're dehydrated or volume overloaded edematous, 90% we will reabsorb. But this 10%, whether I need it back or I should send it in urine, is decided by ADH. So if your blood volume is low, right, the serum osmolality is going high because blood volume is low, blood is more concentrated. So that will stimulate increased production of ADH, right? ADH will go and stimulate this collecting duct to reabsorb that 10% also, right? So now when there is low blood volume, we will reabsorb more and more under the influence of ADH. So the urine that is going out is going to be more concentrated or dilute. Of course, we are reabsorbing water, so urine becomes more concentrated. Urine osmolality will be high or increased. Okay. Now, if let us say I have got the tubular injury, right? PCT, DCT, collecting ducts, they are injured, like in acute tubular necrosis. Can I reabsorb? Reabsorption happens in PCT, DCT, and collecting ducts. Tubular injury means probably these structures are injured. So, will I be able to reabsorb? No. So, I lose more water in urine, and because of that my urine becomes dilute. So urine osmolality will be decreased in acute tubular necrosis. Okay. Now the next most important parameter that you should write for differentiation between pre-renal AKI and acute tubular necrosis. That's the single most important thing that examiner is looking for. That is fractional excretion of sodium. Otherwise you can build this whole table, right? You can also talk about urine specific gravity. Right? Now here the urine is more concentrated, the specific gravity will be high. Here the urine is more dilute, the specific gravity will be low. Those are not something that examiner is keenly looking for. He is mainly looking for FENA. Okay, so what is this FENA? It refers to fractional excretion of sodium. Fractional excretion of sodium means when I give sodium to the kidney, right, through blood, I give sodium to the kidney. Out of this sodium, how much I reabsorb and how much I excrete in urine. That's what we are looking at. Okay. Now you tell me, if you have hypovolemia, pre-renal AKI, you want to reabsorb more sodium or you want to lose more sodium? See, whenever blood volume decreases, right? Whenever there is decrease in BP or hypovolemia, there will be activation of something called as RAS, renin-angiotensin-aldosterone system, in which we have a substance called aldosterone, right? What aldosterone will do? Aldosterone will stimulate absorption of water and sodium. So you are absorbing a lot of water and you are also absorbing a lot of sodium under the conditions where there is hypovolemia or hypotension. So if I have pre-renal AKI, what will happen? I will reabsorb most of the sodium. So the amount of sodium I excrete in urine will be less. My urine sodium is going to be low, right? So thus the percentage of sodium excreted will be low. So the number here is less than 1%. I'm excreting less than 1%. I'm reabsorbing more than 99%. On the other hand, this reabsorption happens at tubules. So if the tubules are damaged, I may not be able to reabsorb good amount of sodium. So I will excrete more. So it will be more than 2%. It will be more than 2%. So these parameters will help us to differentiate between pre-renal AKI and acute tubular necrosis, right? This is something that I want you to write specifically as an important NEET PG MCQ point, as well as something that examiner is keenly observing in your answer sheets. So that completes our approach to the acute kidney injury. Very simple algorithm which you can comfortably write. Right? Whenever you have acute kidney injury, first thing is do an ultrasound or a CT scan. It will find an obstruction, then it is post-renal cause. No obstruction found, then it is pre-renal cause. Next leading clues you can get from the urine microscopy. If urine microscopy is suggestive of glomerulonephritis in the form of dysmorphic RBCs or RBC cast, then you evaluate for the causes for glomerulonephritis. If it shows the renal tubular epithelial cell cast or muddy brown cast, it is pointing towards ATM. And if it is not showing any of these pathological casts, it may be pointing towards pre-renal AKI. In reality, we never have this difficulty because history leads us to the diagnosis, right? If someone comes to me after a road traffic accident, he has bled profusely and then the creatinine is high, I know it is most likely because of blood loss, right? If someone's creatinine jumps after an episode of acute gastroenteritis, I know it is because of dehydration, hypovolemia. But at least for the exams, we will write this algorithm and put a small table differentiating between pre-renal AKI and acute tubular necrosis. Now coming to the management of AKI. Right, of course, it is going to depend on the cause. So management of AKI, start writing with the causes. So first we will talk about the post-renal AKI. How do I treat a post-renal AKI? There is something obstructing the urine flow, so we have to treat by relieve the obstruction either surgically or non-surgically. Surgically or non-surgically means if there is a renal calculi, right, I can do lithotripsy, I can put the basketing, right, I can do that. If there is pyelonephritis, I can do a DJ stenting. If there is a bladder cancer, maybe we can think of the diversion surgeries or the tumor removal or even the bladder removal, whatever possible, do for relieving the obstruction. That is how I manage a post-renal AKI, right? So if it is pre-renal AKI, how do I manage? So if it is a pre-renal AKI, first, right, achieve euvolemia, means try to get the blood volume normalized by IV fluids. With IV fluids, achieve normal blood pressure. If needed, you can definitely consider using inotropic agents to get a normal blood pressure so that the renal perfusion is optimized, right? And then treat underlying cause. The patient is bleeding profusely, right? These measures are temporary, right? How long you can keep giving the fluids, right? Identify from which side he is bleeding and try to do something for stopping the bleeding, right? If there is a traumatized blood vessel, maybe like ligating the blood vessel so that the blood loss gets stopped. If there is acute GE, try to treat, whether like for example if it is cholera, give the antibiotics, treating the underlying cause. And if it is renal AKI, renal AKI is of course treating the underlying cause, because it can be acute tubular necrosis, it could be glomerulonephritis, it could be interstitial nephritis. So if it is the glomerulonephritis, we have to treat the underlying cause. For example, if it is PSGN, nothing specific needs to be done, right? But it's just the supportive care. If it is, let us say, drug induced, we need to withdraw the drugs. If it is like autoimmune causes for the glomerulonephritis, then immunosuppressants. That is how we are going to treat, right? So treat underlying cause. If it is acute interstitial nephritis caused by drugs, withdraw the drugs. Okay, so this is about the management of AKI. Now, in addition to that, we have to also talk about the supportive care that we need to give for a patient with AKI. So what all you should mention here? First, hyperkalemia. If it has happened, how will I treat? Hyperkalemia can be treated with IV dextrose plus insulin. How this will help? Your high amount of potassium in your blood, your kidneys are still not functioning properly, and meanwhile you try to solve your kidney problem, you may end up losing the patient. Because of hyperkalemia, it may trigger a ventricular fibrillation and he may die. So how will I save him from getting into that problem? I will try to quickly get the potassium level in a safe zone while I try to get his kidneys back to function. How can I do that? I can give dextrose plus insulin. Insulin is the important thing here. How it will help? Insulin will shift the potassium from extracellular compartment, from the blood to the intracellular compartment, right? The potassium will go inside the cells from the plasma under the influence of insulin. What else I can do for it? We can also use IV calcium gluconate. This reduces the risk of arrhythmias which are caused by hyperkalemia. Means it stabilizes the cardiac membrane or desensitizes the membrane of the heart, the cell membranes of the cardiac muscles from the potassium. Okay. Then what else we can give? We can give potassium binding resins, which will decrease the absorption of potassium from the food or gut. Example for that is kyaxalate. It's a potassium binding resin. Okay. Second, how do I treat edema? If required, we can cautiously use diuretics. Cautious use of diuretics. Okay. Then how can I treat? What are the other complications we have listed in the clinical features? Uremic symptoms, right? The edema or decreased urine output, we can try to manage with diuretics, of course, only in selected conditions, not in the prerenal AKI. Then third, uremic symptoms. How do I treat uremic symptoms? Uremic symptoms can only be treated by dialysis. You cannot treat the uremic symptoms by any other drugs. You can treat high potassium levels. The fourth thing we have forgotten to mention in the clinical features, it can lead to acidosis, right? It can lead to metabolic acidosis. Metabolic acidosis, and that may present with acidotic breathing, or what you call as Kussmaul's breathing. This can lead to acidotic breathing, and it can also, acidosis suppresses the cardiac function, so it can lead to hypotension. So if there's metabolic acidosis, how do I treat? Metabolic acidosis can be treated with sodium bicarbonate, right? I can try to get the pH somewhat acceptable with the help of sodium bicarbonate. So this is our approach to management of acute kidney injury. Anytime these measures fail, ultimate solution is to go for dialysis, right? Potassium is not coming under control with the anti-hyperkalemia measures. You're not able to achieve a urine output with the help of diuretics, right? You're not able to get the pH to an acceptable range of 7.1 plus with sodium bicarbonate. In all those cases, we go for dialysis. Okay. So from here, we will go to our next question, which is on CKD. What is the difference between acute kidney injury and CKD? The simple thing you should say is that CKD is abnormal kidney functions for persisting for 3 months or more. Acute kidney injury, we have defined it with the numbers. If those numbers are remaining altered for 3 months or more, then it is chronic kidney disease, right? So the question goes like this: define CKD, enumerate the causes for CKD, write the current staging system for CKD, and mention the complications of CKD and their management. This is literally a 20-mark question. The definition of CKD will carry 1 mark. The causes for CKD will carry 2 marks. The current staging system for CKD will carry 2 or 3 marks. Complications of CKD is a 3 to 5 mark question in itself, and the management is also 3 to 5 mark question. Of course, they're not going to ask you to write everything, or if they ask you to write everything, just write in brief. Mostly question will be fragmented, and then they will be asking define CKD, enumerate causes for CKD, and elaborate on the complications, or like enumerate causes for CKD, write staging, and write about management. That is how they make a 10 mark question. So what is CKD? CKD, we will define it as abnormal renal functions, where bracket we can mention as either oliguria, right, or altered RFT, that is creatinine or blood urea, persisting for more than or equal to 3 months. So if creatinine is high for 3 months or more, blood urea is high for 3 months or more, or urine output is low for 3 months or more, then we will call it as chronic kidney disease. Okay. So what are the causes for chronic kidney disease? Here, little bit of epidemiology. The most common cause for chronic kidney disease in India and rest of the world is going to be diabetic nephropathy. So in India, it accounts for 60% of all CKD patients who are on dialysis today, and rest of the world it accounts for 50% or more. So roughly you can say more than 50% or more than half of your chronic kidney disease patients who are waiting for transplantation or who are heading towards dialysis or who are going through dialysis are because of diabetic nephropathy. And the second most common cause is going to be hypertensive nephropathy. Hypertensive nephropathy is the second most common cause. This also accounts for 20-25%. So you can say that if I'm seeing 4 patients on dialysis or renal transplantation today, 3 of them will either have diabetes or hypertension or both, and only 1 of them may be having chronic kidney disease because of some glomerulonephritis or some drug induced or other causes. So the other causes we can mention, chronic glomerulonephritis, then HIVAN, right? What is HIVAN? HIV associated nephropathy. It's a subtype of chronic glomerulonephritis itself, right? It's a subtype of FSGS. Then drugs. And when it comes to drugs, most importantly, it is the long-term use of NSAIDs, which can cause papillary necrosis. NSAIDs can cause prerenal AKI in the acute form, but long-term use can also lead to papillary necrosis, and then they can also become a reason for chronic kidney disease. Okay. And then lupus nephritis, or the SLE, which is again a form of chronic glomerulonephritis. So chronic glomerulonephritis, HIVAN, drugs, and then chronic tubulointerstitial diseases, CTIDs, which refers to chronic, like long-standing diseases which are affecting the tubules and the interstitium, chronic tubulointerstitial diseases, right? So these are the common causes for chronic kidney disease. Now, how do we stage CKD, right? CKD staging includes 2 dimensions. What are those? First, GFR, second, albuminuria. Because you may have normal GFR but still losing albumin in urine, that means your kidneys are damaged. And you may not be losing protein in your urine, but your GFR is going down. That also means kidneys are damaged. So we will have 2 dimensions to the staging of chronic kidney disease, right? So every patient of chronic kidney disease will have a GFR stage and a albuminuria stage. Right? GFR stage will be 5 stages. We will label them as G1, G2, G3, G4, and G5. And albuminuria wise, whether the albumin lost is normal to mildly increased or it's moderate, or it is more than moderate or severely increased amount of albumin is being lost, we will have albuminuria stages as A1, A2 and A3. Okay. So GFR is what I want you to remember. So normal GFR is how much? Around 120 to 125 ml. That is our normal GFR. So if you have a chronic kidney disease, there is evidence of kidney damage and your GFR is more than 90, that is like either normal or high normal, then it will be called as G1, right? GFR more than 90. If it is 60 to 89, we will call it as G2. If it is 45 to 59 or 30 to 44, we will have G3. We will subcategorize it as G3A and G3B. Easy to remember, 90 plus, then 60 to 90, 60 to 90, right? Then 30 to 60. So remember here, more than 90 is your G1, right? Roughly 60 to 90, of course, it is 60 to 89. For exam, just write 60 to 90, that is G2, right? Then 30 to 60 is G3, where we have further subdivided that into G3A and B. A refers to 32, B refers to 30 to 44 and A refers to 45 to 59. Okay, and then when it is 15 to 30, we are going to call it as G4, and less than 15 or anyone started on dialysis, we will call it as G5. We will call it as G5. Clear? So try to remember these numbers. You don't have to precisely write like 45 to 59, 60 to 89. It's perfectly okay to write a closer even number like 90, 60 to 90, 30 to 60, 15 to 30, less than 50. Okay, this is the GFR criteria. And then we also have a albuminuria criteria. Albuminuria criteria, where we are looking at the 24-hour urine albumin or the urine albumin creat ratio, one of them. Okay, if you're looking at urine albumin creat ratio, if it is normal, that is less than 30, it is A1. If it is 30 to 300, it is A2, and if it is more than 300, it is A3. So try to memorize this and vomit it out on the paper to get that marks for the staging of CKD. Okay. Now after the staging of CKD, we will talk about the complications of chronic kidney disease. What complications we are expecting in a patient with chronic kidney disease. Okay, so in the complications, first thing that we will mention is the fluid overload. Fluid overload, because kidneys are supposed to eliminate the excess fluid that we are taking in. If they are not able to do, there will be fluid overload. The patient will present with edema, pleural effusion, ascites, right? These are the manifestations of fluid overload that can lead to shortness of breath and other symptoms. Okay. Next, after the fluid overload, what else can chronic kidney disease lead to? Chronic kidney disease, please remember, kidneys are playing an important role in regulation of your hemoglobin level because they are producing erythropoietin. And if kidneys are damaged, the erythropoietin production will come down and we will get into anemia, right? We will call this condition as anemia of chronic kidney disease. Usually examiners expect you to write the mechanisms for the anemia of chronic kidney disease, right? The main reason, the most important reason is decreased erythropoietin production. Decreased erythropoietin production, but that's not the only reason. The anemia of CKD is also because of decreased iron store, right? There is decreased appetite. Patients of CKD are not able to eat well, right? Due to why? Uremia. I have already told you uremia induces nausea and vomiting, so they don't tolerate food well. If they're not eating well, they're not getting sufficient iron, sufficient protein, sufficient vitamin C, right? Sufficient cofactors required for heme synthesis. So they will have anemia, so decreased appetite. Then fourth, there will be increased inflammatory cytokines. CKD is an inflammatory condition. Inflammatory cytokines like interleukin 1. And what these inflammatory cytokines will do? These inflammatory cytokines will decrease iron absorption, decrease iron absorption. So these are all mechanisms which are responsible for the anemia of chronic kidney disease. Okay. Third, there will be secondary hyperparathyroidism. Secondary hyperparathyroidism. What do I mean by that? In CKD, what happens is there is decreased phosphate excretion, because kidneys are supposed to excrete the phosphate also, but they are not able to do that. So once there is decreased phosphate excretion, this will stimulate the parathormone production. So this will stimulate increased PTH production. Now what this parathormone will do now? Parathormone will go to the bones, dig the bones and bring the calcium out. So this can lead to increased bone turnover, right? Bone turnover. And because of the increased bone turnover, we can develop a complication called as osteitis fibrosa cystica. Osteitis fibrosa cystica and increased fracture risk. Many patients of CKD end up developing severe fractures, especially the spine fractures, hip joint fractures. Okay, so that is one complication related to secondary hyperparathyroidism. Okay. Now to counter this, what normally doctors tend to do, decrease the phosphate intake, right? That's what we do as doctors. And when we decrease the phosphate intake, if we do it too much, what will happen? If the blood phosphate level decreases too much, then there will be suppression of parathormone. If the parathormone gets suppressed, then what will happen to the bone turnover? It will get reduced less than normal. We will call it as adynamic bone disease. So we have one more complication that we can encounter in these patients, which is called as adynamic bone disease. Adynamic bone disease. So what is happening here? So if you had secondary hyperparathyroidism and you try to treat it, treated with phosphate restriction, and calcimimetics, can lead to PTH suppression. And if there is suppression of parathormone, then bone turnover gets reduced, right? So there will be decreased bone turnover, no bone turnover happening at all. That is what we call as adynamic bone disease. And this decreased bone turnover also leads to increased risk of fractures and delayed fracture healing. Because there is no bone turnover happening at all, right? So you're not able to build new bone. You develop fractures and you're not able to repair them because that bone turnover is decreased. This condition we call it as adynamic bone disease. That is the fourth complication. Okay. What is the fifth complication that we can expect? Hyperkalemia. Why hyperkalemia is happening? Due to decreased renal potassium elimination, that is leading to hyperkalemia. Now how will I treat? Of course, anti-hyperkalemia measures. I'll come to that. What complications it can lead to? This can lead to ventricular arrhythmias and cardiac arrest. Ventricular arrhythmias and cardiac arrest. If you have time, definitely you can write a little bit about the ECG changes that you can get, the tall T waves and the sine wave change. Okay. What else I can expect in patients with CKD? What else do we expect in patients with CKD? We have spoken about the impact of chronic kidney disease on the fluid, electrolytes, anemia, endocrine manifestations with respect to the bone. What else it can lead to? Acid base imbalance, right? It can lead to metabolic acidosis. Why metabolic acidosis happens? Because decreased bicarbonate reabsorption. You're not able to reabsorb the base, and you're not able to eliminate the protons or H plus ions. Decreased H plus excretion. So you're neither able to excrete acid molecules nor able to reabsorb sufficient base molecules. So you're developing metabolic acidosis, right? So these are all the common complications of chronic kidney disease. Now, how will I manage a patient with chronic kidney disease? Okay, so management will depend on the complications and the first line management and definitive management. We'll put a table so that it becomes simple in the exam, right? So we will first write about, now first thing is that even before we talk about the complications, right? Slowing the disease progression. Like let us say I've got a patient with stage 2 CKD. I don't want him to go to stage 3. I don't want him to go to stage 4. Slowing the disease progression. How can I slow down the disease progression? What are the most common causes for CKD? First one is diabetic nephropathy. Second one is hypertension, right? So if you control their diabetes and hypertension, you can slow down the progression, right? So you need to have glycemic control, right? HbA1c less than 7%, and then you should also have a BP control. So you have a target BP control to less than 130 by 80 millimeters of mercury. Okay. Apart from that, certain drugs are known to slow down the progression of CKD. What are those? AC inhibitors and SGLT2 inhibitors. Regardless of whether a person is diabetic or not, AC inhibitors and SGLT inhibitors can slow down the progression of CKD, right? Second one is management of complications. Management of complications. So how will I manage a complication of CKD? So we'll on one side write the complication, first line management and second line management. So let us have a small table. Complications, first line management, management of refractory or those who are not responding to first line. Okay, so in terms of complications, first let us say fluid overload. Your kidneys are not able to eliminate urine, oliguric. What can I do? So here, one thing I can do is fluid restriction. Restrict the amount of fluid that patient is taking depending on his urine output. Second thing I can consider is doing diuretics, right? If fluid restriction and diuretics don't help, then I have to go for dialysis. Second, if patient has got hyperkalemia, how will I treat? If there is hyperkalemia, how can I treat? First line management is potassium restriction in the diet. Like that's why most of the CKD patients are advised not to eat fruits, right? Potassium restricted diet and anti-hyperkalemia measures. Anti-hyperkalemia measures. Under this anti-hyperkalemia measures, of course, we will include insulin, then salbutamol nebulization, which will again shift the potassium from extracellular to intracellular compartment. Then we will include calcium gluconate, which reduces the risk of arrhythmias because of hyperkalemia, calcium gluconate, and potassium binders or potassium binding regimens. Examples we have already written, Kyaxalate. If that fails, again I go for dialysis. Okay. Then the next complication that we should be talking about is let's say uremia, right? Symptomatic or uremic symptoms. Uremia, increased blood urea or nitrogenous waste. There is nothing that I can do as first line. If the symptoms are severe enough, I have to go for dialysis. I have to go for dialysis. There is no way to reduce the urea. Only dialysis can do. Okay. Then fourth, anemia of CKD, anemia of chronic kidney disease, right? How do I manage? First line management, there is nothing called second line management. We can write second line management if required. First line management is iron replacement because they do have iron deficiency, and then erythropoietin or darbepoetin injections. Darbepoetin, which is a synthetic analog, recombinant analog, darbepoetin injection. The refractory cases, of course, you can consider blood transfusion. Blood transfusion. Okay. Now the next complication that we can talk about here is the increased bone turnover, or what we call as CKD related mineral bone disease, where there is increased bone turnover, or you can also call it as secondary hyperparathyroidism. So how will I treat it? Okay, so the first line management here will be phosphate restriction in the diet, then phosphate binders, which will bind the phosphate and eliminate in stool. You don't absorb it even if it is coming in your diet, right? Example for phosphate binder is sevelamer. Okay, what else I can do? I can do calcium and vitamin D supplementation to suppress the parathormone. If that doesn't work, I can think of something called as calcimimetics. How these calcimimetics work? They are substances which act like calcium. They don't do the function of calcium, but on the parathyroid gland, they behave like calcium. So parathyroid gland gets confused that, oh, there is so much calcium, I should not produce more parathormone, and we will be able to suppress. So basically what happens is, if this is my parathyroid glands, right? These parathyroid glands, on top of them, they have receptors called as CASR, calcium sensing receptors. So whenever blood calcium levels, right, either increases or decreases, the parathyroid gland will get to know with the help of this calcium sensing receptors. If too much of calcium sensing receptors are getting bound by calcium, then parathyroid gland knows that blood calcium is high. No need for me to send parathyroid hormone to the circulation. Right. So now instead of using calcium, I can give drugs like the sinacalcet, which is a calcimimetic. This will go and bind this CASR receptor, and now the parathyroid gland will be tricked to believe that blood calcium is high, so I don't need to come out. That's how we can suppress the parathyroid hormone production. Calcimimetics like sinacalcet or etacalcide, these can be used. Okay, then sixth, if there is metabolic alkalosis. I forgot to mention what should I do if there is adynamic bone disease. If there is adynamic bone disease, that means there is decreased bone turnover, right? So in such cases, we need to decrease calcium and vitamin D supplementation, and then we have to maintain phosphate levels in the blood. So if the phosphate levels go too low, I can end up getting adynamic bone disease. So we try to maintain that. Okay, now how will I manage if there is metabolic alkalosis? The metabolic alkalosis, we will acidosis, we will try to manage with first line management will be sodium bicarbonate. The definitive management, if sodium bicarbonate doesn't work, is dialysis. Remove those acid molecules through dialysis. So this is the management of all the complications of CKD, right? How do you manage CKD related mineral bone disease? How do you manage adynamic bone disease? How do you manage metabolic acidosis? How do you manage the anemia of CKD? How do you manage the uremic symptoms? All the complications are covered. Now, only extra point that we would write and close the session today is about dialysis. Right, the last thing that is pending. We are told that dialysis. Now we have to talk about dialysis a little bit. So, what is dialysis? Dialysis refers to removal of nitrogenous and other metabolic waste through artificial systems other than kidney. Artificial systems other than kidney. So instead of kidney, we are trying to use some other system to remove this nitrogenous waste. Then we call it as dialysis. Now, how many types of dialysis are there and what are the indications? So indications for dialysis. When do we need to start dialysis? Okay, so the indications for dialysis are: number 1, acute kidney injury with refractory hyperkalemia, oliguria, or uremic complications. So potassium is very high, or the metabolic acidosis which is not responding to treatment, or urine output that is not coming out despite all our treatment. So the word that we should mention is refractory, right? Or CKD stage 4 or 5. That is where we generally think of initiating the dialysis prophylactically instead of reaching a stage where all these complications are non-manageable and then we start dialysis. It is better that once they reach stage 4 or 5, we should start the dialysis. And then you have to also remember, for toxicological clearance. So whenever, like, there are a lot of dialyzable drugs, if there is poisoning by any of those drugs which are dialyzable, we can also consider dialysis, right? Now the question is, what are the types of dialysis that we are aware of? Types of dialysis. So there are two main types of dialysis, because in dialysis the blood is made to pass through a chamber across a membrane. So how the dialysis works is, there is a chamber. What is that chamber? We'll come to that later. And in the chamber there is a membrane which separates. There is a blood compartment and there is a dialysate fluid compartment. Means we have added some fluid in a compartment, and these two are separated by a dialyzer membrane, right? Dialyzer membrane. And this membrane allows the diffusion of small molecular weight substances. So because of the concentration gradient, the molecules will diffuse. Now in a patient with CKD, their blood has very high amount of potassium, right? It has very high amount of urea, it has very high amount of other nitrogenous waste. But the fluid that I have put here as dialysate fluid, this carries lesser amount of potassium, right? Lesser amount of urea, lesser amount of nitrogenous waste. And because of the concentration gradient, the potassium will diffuse into this dialysate fluid, urea will diffuse into the dialysate fluid, and this dialysate fluid I will discard, and the blood I will give it back to the patient's body. That is how the dialysis works. It's a very simple principle. Okay. Now, whether I make this blood to go through a artificial chamber which is having a blood compartment and a dialysate compartment and a synthetic membrane, or why not utilize a bioavailable membrane within our body, which is the peritoneum, right? Our peritoneum allows the diffusion of small molecular weight substances. So instead, I can directly put the dialysate fluid into our peritoneum. The peritoneum becomes the dialysate compartment and our blood vessels have the blood. So now from our blood into that peritoneal fluid that I have added, the potassium, urea, everything will diffuse, and the dialysis fluid after the dialysis is done, I can discard it. So this we will call it as peritoneal dialysis. When I make the blood go through an external chamber, we will call it as hemodialysis. So we will have the types of dialysis. We will have two major types of dialysis. Right. So dialysis will have two major types: the peritoneal dialysis and hemodialysis. Peritoneal dialysis and hemodialysis. So in peritoneal dialysis, peritoneum acts as dialyzer membrane. In hemodialysis, synthetic dialyzer membrane or artificial dialyzer membrane is used. That's the main difference. Okay. So now in the hemodialysis, we have further types. What are those types? One of them is called as continuous renal replacement therapy. Continuous renal replacement therapy, slow, low efficacy dialysis, and intermittent hemodialysis. These are the three subtypes of hemodialysis. Basically, how long we do dialysis is the factor. So if dialysis runs, means the patient is hooked to the dialysis machine 24/7 and the dialysis is continuously running, just like how normal kidneys work, right? How normal kidneys work? 24/7, round the clock, the blood goes to the kidney, 20% of cardiac output always goes to kidney. Kidneys are creating a glomerular filtrate, reabsorbing unwanted, we are excreting in urine. So this process is running round the clock. Trying to come close to this normal physiology is CRRT, which refers to continuous renal replacement therapy. Right? So where dialysis is done for 24 hours, 7 days a week. Okay. Then SLED refers to slow, low efficacy dialysis. So this is a subtype of intermittent dialysis. Intermittent dialysis done for patients with hemodynamic instability. Now, why are we doing it for hemodynamic instability patients? See, normally when we do dialysis, at any given point of time, large amount of blood is coming out from the patient body and going into the dialysis machine. So that blood is not in patient circulation. So patient has a tendency to go into hypotension. So if I do the regular dialysis, patient's hypotension will get even worsened. Normally, there's a tendency that hypotension may happen during dialysis, and if they're already hemodynamically unstable, it will worsen their hemodynamic stability. So what we will do is, instead of making the large amount of blood come out of the body to go to that machine, we will make it come out of the body slowly and go to the machine. Of course, I need to run the dialysis for a longer period of time, right? Then the intermittent hemodialysis is, for most patients, this is the method that is followed. Hemodialysis done 2 to 3 times a week, 2 to 4 hours per session. So every time patient comes, he will be hooked to dialysis machine. 2 to 4 hours, we will run the dialysis. During this period, we will try to extract maximum amount of nitrogenous waste and remove it. Again, he will come back after a gap of 1 day or 2 days, depending on the severity of his condition. During this period, the nitrogenous waste will reaccumulate in his body, and then when he comes for dialysis, we'll re-remove it. Again, for next 1 or 2 days, it will reaccumulate, we will re-remove it. Of course, this is not going very close to physiology, but it is convenient because patient need not be hooked to the machine 24/7. CRRT is the closest we can get to physiology, but patient is connected to machine 24 hours, so he is not going to be ambulating comfortably, right? He will be in his home, confined to bed, and is undergoing dialysis continuously. This is the most commonly followed dialysis method. Okay. Peritoneal dialysis, yes, it gives the advantage to the patient that patient can be ambulatory, right? Put the fluid into your peritoneal cavity and keep moving around. The dialysis will go on naturally inside your peritoneal cavity, right? Now that is about dialysis. We will mention about the side effects of dialysis or complications of dialysis and then close the session for today. Complications of dialysis. So under the complications, first we will talk about peritoneal dialysis. And then we will talk about the hemodialysis. So peritoneal dialysis main complication is something called a CAPD peritonitis. What is it? CAPD refers to continuous ambulatory peritoneal dialysis, and that dialysis catheter gets infected and the infection can get into your peritoneum. Of course, a very major concern. Hemodialysis, the main complications are one, hypotension. Hypotension is the most common complication that we can encounter in these patients. It's the most common complication. Most common complication of hemodialysis, because blood comes out from the body in large volume and goes to the machine. So circulating blood volume is quickly depleted. Okay. What else it can lead to? There is something called as dialyzer reactions. Dialyzer reaction. There are different types of it. Right now, no need to bother about it. Just remember, the patients can experience certain reactions when he is going through dialysis. We will call them as dialyzer reactions. Okay. The third one, there is something called as dialysis disequilibrium. Dialysis disequilibrium syndrome. What is this? Development of cerebral edema due to rapid dialysis. So during what happens, the first dialysis that we do for the patient, he's having high amount of urea, creatine and other osmotically active substances in his blood for a very long period of time, right? Few months, few years before we start the dialysis. During that time, all his biological systems, including brain cells, are used to that high osmotic fluid or high osmolality of your blood. Now I remove the urea suddenly, the blood osmolality comes down. Right, blood osmolality comes down. That can trigger the cerebral edema, just like how hyponatremia triggers brain edema. Similarly, this sudden decrease in the blood urea levels can trigger the brain edema, and because of that, patient can become increasingly disoriented, confused, and it can be even life-threatening. So that is why you see any of your relatives or your patients who are being started on dialysis, the first dialysis is always for a short period. We do not want to bring down the urea levels quickly, right? So what is this? This is cerebral edema due to rapid decrease in blood urea. Okay, so that completes the discussion on the dialysis, and we have catered to the major question that can be asked from nephrology. Of course, there can be 3 or 5 marks question on the glomerular disorders, mainly PSGN, IgA nephropathy, membranoproliferative glomerulonephritis, and membranous nephropathy. For all those 4 or 5, 3 marks, 5 mark question, points you have to mention in the paper is one, the cause and the management, whether it is supportive or immunosuppressant. Second, complements, whether they are normal, decreased or not. And then the third is the histopathological findings that you get, right? So that you can get from the Farre section. There is a question on the nephritic syndrome which addresses that. And once you're done with that, you're kind of prepared for nephrology. There may be question on nephrotic syndrome. Nothing much from the adult medicine side for nephrotic syndrome. So whatever Sharat sir has covered in the pediatrics, that is something that you can replicate again in the adult nephrotic syndrome. Only thing I want you to remember with respect to adult nephrotic syndrome is that you should be able to mention the causes. In the children, it is only MCD, but in adults, FSGS, right, membranous nephropathy, and minimal change disease, you can mention, and the diabetic nephropathy as causes for the nephrotic syndrome. Okay, So from me, that's it today. From tomorrow onwards, I think for next 3 days, OBG is taking over. I will be back after that, and we will continue with the other systems. The notes will be shared to you on the Telegram. Thank you guys. See you. But Amir, I have told them they are going to upload within a very short span of time.